We will be online in video conference soon. Here we are. A round of applause, please.
Hello.
You are
I'm going to share my screen. Okay, I'm getting an echo, so I'm going to turn off my sound. Can you hear me? Okay, I'm going to turn off my sound. Anyway, welcome. I apologize for any technical difficulties. I've been waiting to give this talk. I hope you're all having a good day. I'm going to present to you today a very shortened version of Cannabis and the Future of Psychiatry. I want to make a statement. We hear a lot of problems confusing the situation with recreational cannabis with a very different situation when people are using it for therapeutic reasons. So let me read this statement. There is a world of difference between recreational studies of cannabis, wherein the goal is to produce intoxication, release, or an altered state of consciousness, as compared to its therapeutic application, wherein the intention is to attain symptom relief at much lower dosages without adverse events, including psychiatric symptoms. Now, you may have heard this before, but the CB1 receptor, where THC works, as well as the endocannabinoids, is highly expressed in the brain, particularly in areas that have to do with emotion, limbic system, also the reward pathways, but you cannot cause an overdose with a cannabinoid that will arrest respiration like opioids can. When the CB1 receptor is stimulated, it inhibits the release of neurotransmitters, and that makes it a neuromodulatory system. If there were one article that you were going to read about the effects of cannabis in the psychiatric area, it would be this one by Zach Walsh and colleagues, which I highly recommend, in Clinical Psychology Reviews 2017. And we'll be using some slides from it. I wanted to point to a recent study, an observational study in Israel, that gives you an idea of what a difference this can make. They had 188 patients that were averaging about 80 milligrams of cannabidiol a day and a low 4 milligrams of THC 3 times a day. After 6 months, almost 87% of the patients continued treatment, and there were very marked improvements on mood and 63.5% improvement in the activities of daily living and about 43%. Good sleep for 25%, good concentration for 14%. And these were all highly statistically significant. 80% of patients reported at least a moderate or significant improvement. In almost every clinical trial that's done over a period of time, and in almost every survey of cannabis use therapeutically, we see improvements on sleep. This is from an old article in 2007, but even then, with studies of side effects, in almost every case, there was marked improvement in sleep disturbance alleviation. And this is an interesting effect because it's not due to the sedative effects of cannabis so much, but rather reduction of symptoms like pain, or spasticity, or spasms, or lower urinary tract symptoms that accounted for these improvements. And in the last 12 years, all the information seems to support this effect. Now let's turn to post-traumatic stress. There are strong underlying bases for feeling that the endocannabinoid system is very important in this condition. We know that cannabinoids can produce extinction of aversive memories. In other words, help people to forget the trauma that they've been through. There also is a role for cannabinoids in what's called stress-induced analgesia, reduction of pain control under stress, which is very much part of post-traumatic stress. Additionally, it's been hypothesized that there's a central anandamide deficiency that predicts stress-induced anxiety. In other words, post-traumatic stress may be a clinical endocannabinoid deficiency state. In terms of studies, and this is from Zach Walsh's review, at the time of his review, there were 4 studies of medical use of cannabis for post-traumatic stress, and a substantial portion of symptoms have been relieved by cannabis by reports. Again, there have been self-reports of good outcomes with improvements in sleep and particularly reducing nightmares. One of the effects of THC is to reduce REM sleep that leads to dreaming and nightmares. Matt Hill and his colleagues did a very interesting study a few years ago. They looked at 46 survivors of the World Trade Center 9/11 disaster. There were 2 groups, those that developed post-traumatic stress and those that did not. The serum 2-arachidonoglycerol, the endocannabinoid level, was significantly reduced in the victims who had post-traumatic stress symptoms as compared to those who were spared that. And so there was a improvement in the aversive memories associated with that. The results seem to suggest a good correlation of lower serum anandamide levels to increased CB1 receptor binding sites in the central nervous system. So again, this is an illustration of the importance of the endocannabinoid system in the psychiatric condition. Another one from Zach, looking at depression. There were 4 reviews of non-medical use, and there have been suggestions, but not proof of causation, that people that use a lot of cannabis might be prone to depression. But in 9 studies of therapeutic use, 7 noted improvements in depression, and only 1 reported an association between depression severity and problematic cannabis use. Going back to a study that I did with colleagues, reported back in 2002, there were 4 patients who received large amounts of cannabis legally through the American government, if you can believe it. And they all had very severe disorders that normally are associated with severe depression. And you see here the Beck Depression Inventory 2 and the scales. So a mild depression begins at a score of 18 and goes up from there. But in the 4 patients, 1 had a score of 6, which is not at all depressed, and the other 3 had scores of 0. And these are people with terrible conditions whose quality of life without cannabis was terrible. 2 of these were addicted to opioids, even intravenously. So obviously there's been great improvement in their condition psychiatrically and no evidence of depression. There again has been a whole controversy related to cannabis and psychosis. Many people have tried to claim that psychosis can be initiated by cannabis usage. We do know that there is an association in at-risk individuals, particularly at a young age, in unmasking a tendency towards schizophrenia. But a study was done in England in 2009, answering the question, how many cannabis users may need to be prevented in order to prevent 1 case of schizophrenia. In other words, if you could use a magic wand and eliminate cannabis usage, what difference would it make on schizophrenia? Well, what they found out was that in the male population, the number needed to prevent schizophrenia ranged from 2,800 to 4,700, depending on age. And for females, it was similarly ridiculous. You would need to prevent cannabis use between 5,470 and 10,870 patients to prevent 1 case of schizophrenia. Additionally, we know that if we compare the prevalence of schizophrenia in the 1960s to currently, it's actually gone down a little bit. Whereas the use of cannabis is spread all over the globe. And if there were a positive factor of cannabis in the production of schizophrenia, we surely would see this reflected in public health studies, and it just is not there. On the positive side, there have been 2 phase 2 clinical trials using cannabidiol to treat schizophrenia. The first was by Levica et al. In 2012. They compared cannabidiol 800 milligrams per day to amisulpride, which is an atypical antipsychotic. This is in 42 patients for 4 weeks. The positive and negative syndrome scores were improved in each group, but the negative symptoms were notably better on cannabidiol. Additionally, the side effects that are quite prominent with the atypical antipsychotics, including extrapyramidal movement disorders, weight gain, and elevations of the prolactin hormone levels, were all not evident with cannabidiol. In other words, just as good as with many fewer side effects. A more recent study was reported in 2018, again, a phase 2 clinical trial. In this instance, there were 45 controls on antipsychotics compared to 43 on 1,000 milligrams of pure CBD that was divided on twice-a-day dosing over 6 weeks. The positive psychotic symptoms decreased on cannabidiol, and that was statistically significant. But clinician ratings favored cannabidiol over the other agents, and also the motor speed, how quickly people could move, also favored cannabidiol. So clearly this is a drug for the future. We know that the atypical antipsychotics have a lot of side effects, and patients don't tend to stay on them if they have a choice. In terms of acute reactions, there is a phenomenon called toxic psychosis when someone takes too much THC. So a person will become agitated, delusional, paranoid. This has been seen with doses as low as 10 or 15 milligrams of pure THC, such as synthetic THC and marinol. And you see that on the left. There was a study done where very, very high doses of Sativex had to be taken, given to patients to show that there was no problem with cardiac conduction. And they got 48 milligrams of THC along with cannabidiol. You see then that there were only 4 incidents of toxic psychosis out of about 240 exposures. So what happened was the presence of cannabidiol and terpenoids improved the therapeutic index of THC such that doses 3 times higher could be taken without producing toxic psychosis. As far as anxiety, again, there have been associations in literature between cannabis use and anxiety, but no evidence of causation. In Walsh's study, they looked at 8 medical studies. 8 reported relief of anxiety as a primary or secondary benefit. And then from more recent data, observational studies, this one reported earlier this year, they were looking at a large proportion of patients with anxiety and depression. This is from Canada, people using cannabis medicinally. Half of the anxious sample reported substituting a prescribed medication with cannabis to some degree. 61% indicated that cannabis had completely replaced the prescribed drug. The drugs that were most often cited as being replaced were antidepressants and benzodiazepines. I think everyone's aware how hard it can be to get off of those drugs. Also, as you might expect, reduction in pain reliever use. So this is an interesting observation. A study from Israel reported in 2018 in an unselected population of patients using cannabis, there was a marked reduction on opioid use. 344 patients, or about a third, were on opioids at onset, and 36% were able to continue them. 9.9% decreased the dose, and there was only a tiny percentage that increased, and the rest remained stable. Also interesting were that anxiety and depression declined by 84%. So these are not randomized controlled trials, but clearly there are trends here that require follow-up. And that's the end of this brief presentation. I wonder if we have time to answer questions. I hope that we do. Hello.
This camera, right?
This camera, right?
Same camera? We cannot see
Okay,
it.
so let's see, and you can please tell me when to stop.
Oh, there's camera? Okay.
Yeah.
Can you see us, Ethan?
I can see the crowd.
Okay, can you see anything moving?
No.
Front row?
He
Looks frozen.
doesn't see you.
Okay, it doesn't matter.
Okay.
You don't need me. Okay.
So
Just need to
far,
hear us.
we don't have questions in the app. Is there any question in the audience?
Somebody must have a question for Dr. Ethan Russo. There we go.
There we go.
Microphone, please.
Hello, doctor. My name is Humberto. My question is how it is to work with big pharma companies in a time where most government institutions wouldn't allow us to investigate the plant. How it is to work with these specific institutions with this plant.
I had a little trouble hearing, but you know, I think that the question is how can people utilize the plant when there's so much opposition from governments? This is always the problem. You in Portugal have had benefit of decriminalization of drugs for many years, but have not had corresponding good access to cannabis. This is a very sad state of affairs. I think that the only solution to this can be from electing leaders that will understand that potential medicine doesn't do anyone any good. So there has to be access to appropriate medical grade types of cannabis so that patients can have their conditions treated more effectively. I hope that that answers the question.
Thank you. Anybody else for Dr. Russo? Ma'am?
Just a question about heavy metal toxicity and the role of that along with this anandamide deficiency. Many patients I see, they've suffered maybe from PTSD disorder, but they've been in the military and they've been exposed to lead, and if I do a level, sometimes that's high, and often we'll have to treat them with chelation. But has there been any research on that specific heavy metals and the endocannabinoid system?
Okay. The problem is that cannabis is a bioaccumulator. This is helpful if, for example, you're growing hemp on the site of a nuclear disaster like Chernobyl. It can get the radioactivity out of the soil, but then you have to dispose of the hemp. The same thing will happen if medical cannabis is grown in an area with heavy metal contamination. So one of the safety measures that's necessary with cannabis should be the use of assays for chemicals, because if these are in the material that's inhaled or ingested, it clearly will be absorbed into the body. Another issue is whether cannabinoids can help with symptoms of heavy metal exposure. And the answer is perhaps. There has not been any formal testing in clinical trials. But this may be part of the solution along with chelation and other approaches, but clearly the best approach is one of prevention. So we have to limit environmental exposure. And again, this comes through laws and good monitoring of cannabis material that people purchase.
Thank you.
Okay. Yeah,
Anybody
we have
else?
two
One
more.
Yes, ma'am?
Hi, Dr. Russo. I'm from Canada, and many of the studies that you've spoken about talk about doses of 800 milligrams or 1,000 milligrams a day. In Canada, we're incredibly restricted by the dilution factors that the government imposes on cannabis companies. I'm curious what your opinion is on what is a therapeutic dose for cannabis for treating psychiatric conditions.
Yeah. Well, it varies with the condition. In the case of schizophrenia, as you saw, the doses for pure cannabidiol were really elevated, 800 to 1,000 milligrams a day. This is totally impractical for the vast majority of people. And clearly within the Canadian system, you can't get that amount without drinking a liter of oil, which is clearly inadvisable. The problem is, I believe that one could get an equivalent benefit with much lower doses of cannabidiol if a tiny amount of THC is present. The problem is psychiatrists are deathly afraid of giving any amount of THC to the patients with schizophrenia, but based on the data that we have from treatment of severe epilepsy, it is likely that you could cut cannabidiol's doses about 80% if there were other cannabis components present as well. So I'd like to see this work be done and answer the questions better. For depression and for anxiety, again, I think the doses required are much, much lower than the situation with doses of cannabidiol to treat psychosis.
Okay, so one more
I think
question.
there's one more question over here.
Please.
Okay, thank you for the presentation. My question is, what is the evidence right now about the use of cannabis in the abuse or addiction of benzodiazepines, like the use that have been done with opioids?
Right.
Thank you.
Sure. There is a general effect of cannabis use to reduce dependency on a variety of other agents, and that includes benzodiazepines. But in the slides, you saw one of the best pieces of evidence. We've seen benzodiazepine sparing in a number of observational studies. Again, these haven't been in randomized controlled trials, and so most physicians aren't going to pay a lot of attention to it. But we do have evidence now of this, and hopefully this will allow more formal studies that are going to be more convincing to our medical colleagues.
Okay.
Final question.
Hi, Ethan. It's Javier from Spain. I would like to know what's your personal opinion about the schizophrenic patient that use cannabis with THC as self-medication. Do you think they use it because of the improvement of the side effects of the antipsychotic medication, or because of the improvement of the negative symptoms of the schizophrenia?
Yeah, again, I had a little trouble hearing, but we know that statistically, people with schizophrenia use a lot of substances. They use a lot of cannabis. They use a lot of alcohol. They use a lot of stimulants. And the reasons can be because it reduces symptoms, or again, it may be attempts at self-treatment. The real issue is how dangerous is it? What are the best approaches? And we have a signal clearly that cannabidiol is helpful, and likely it's best to have a lot more cannabidiol than THC as a treatment option. But again, there's a lot of work to be done here to establish the best practice.
Thank you.
Thank you.